a very warm welcome. I'm going to start now because we have a very full agenda. Very warm welcome to you all to the NAPP 2017 annual conference entitled, and don't forget it, Patience, Partnership and Power. Before I hand over to our patron, Sir Dennis Prayer-Gray, who will chair and introduce our keynote speakers, I have to thank the General Medical Council for, and the exhibitors, but particularly the General Medical Council first. We are most grateful to them for sponsoring this exhibition this year, and we hope that we will continue to work with the GMC to run several other interesting projects. Also thanks to all those who've taken stands. Please go and visit them. We depend on it, and they depend on it, and they wish to hear from you all. We are living in the most interesting but challenging times. We know that politically. It is particularly challenging for general practice and indeed for the NHS. However, I believe that we, as patients, are part of the solution. Learning to work constructively with our own doctor on an individual basis, working with the practice and supporting the practice, but in a balanced and fair way, but also being prepared to challenge policymakers at national level. That is part of the NAPP role. I particularly like the words of Joan Mant, who was a founder member of NAPP. She said, "Patients have more to offer than their illnesses." I think the committee has produced, your committee, a most exciting and varied programme of speakers and workshops. They do amazing work, and you do amazing work, so enjoy the conference. Now I'm going to introduce Sir Dennis, and in case any of you don't know Sir Dennis, who is our patron, he needs little introduction, but he was a GP for some 38 years in St Leonard's Medical Practice in Exeter, where he is still a research consultant, and where he followed his father and his grandfather. He is an emeritus professor at Exeter University and a prolific author of academic papers. He has been chairman of the council and president of the RCGP, chairman of the board of trustees of Nuffield, and the only GP to be the chairman of the Academy of Medical Royal Colleges. He is also a patron of NAPP and an extraordinarily good help to me personally. Dennis, thank you.
Thank you very much, Madam President. I'd like to begin by saying how privileged I feel to be the patron of NAPP and to have the chance of chairing this conference. I've been an enthusiastic supporter of patient participation since 1974 in a variety of settings, and I believe this is one of the great unifying themes with enormous potential for the NHS. I think it's absolutely wonderful to see a room where we seem to be completely packed out. I hope nobody's left standing. There may be one, but it's really encouraging to see a room as full and enthusiastic as we are today. The Department of Health says that its strategic policy is to put the patient at the heart of everything. I think all of us feel we're some way away from that. And the role of this conference, the role of NAPP, is to make things happen. And I look forward to listening to the speakers and to the groups during the day to hear all the ideas that usually bubble up in these conferences. I'm going to begin by introducing our first speaker. It's a particular pleasure for me to introduce Professor Hungin because I've known him for many years. General practitioners are very disadvantaged academically in the opportunities they get to acquire higher university degrees. It's much, much easier for specialists to do so. So there's a real shortage of GPs with higher intellectual skills. And many years ago, Professor Hungin emerged in the north of England by getting a group of GPs together in a relatively deprived area and saying, let's all get MDs. Nowhere else in England did this happen. He kept them together, he led them, he got an MD himself, he encouraged them, he nurtured them, and lo and behold, a whole block of them acquired the highest research degree in Britain from general practice. It was an inspiring example of leadership and an early sign of his huge potential. He went on to become a professor of general practice and one of the very few GPs to be dean of a British medical school. In his case, it was Durham. Even today, there are only 2 GP deans of any medical school in the United Kingdom, so it's a fairly rare phenomenon. Pali Hungin achieved that at Durham. And now, more recently, he has been elected the president of the BMA. That's an interesting post, and it gives him a leadership opportunity which he has seized with both hands. And he has initiated a series of meetings and a big national conference where he got international quality speakers to look at the future of medicine. The really challenging question, which only a leader could see needed to be done, leading a national organisation with the resources to look at it. That report, I understand, is about to be released, but it's another example of his leadership skills. So it's a very special pleasure, Madam President, to introduce Professor Pali Hungin.
Thank you very much, Dennis, for that very warm welcome. And it's such a pleasure to see you both, Patricia and Dennis, here. And a wonderfully full room, which is so beautifully indicative of the level of interest and indeed commitment to this area of patient participation. Although I'm speaking as the current president of the BMA, I will be rather free in my remarks in that my reign is finishing in about 3 days' time. I feel a little like the Duke of Edinburgh this morning in that sense, unfettered. I want to say from the outset that my own feelings are very similar to those that Dennis has expressed. Our practice was amongst the first in the north of England to set up a patient participation group. And latterly, as members of our family have experienced health problems, we have become patients ourselves. And I can see things from every direction. Indeed, I doubt if there's anyone in this room who hasn't experienced things from the patient side of things as a member of the public and, of course, as a member of the profession. So what I'm going to talk about today is underscored underscored by the plight of doctors and of medicine. But what we're really talking about also at the same time is how this is going to affect us all as patients. I want to make a simple but possibly contentious statement immediately, which is that I think that the title of this meeting, it's strapline, power, the word power is in the strapline for this meeting, is absolutely crucial. I think that the challenging times in which we are now require the use of power. And it is my strong feeling that this power will need to come from not just the electorate in this country, but from people, from the public, from patients all over the world. But before I go into my theme, let me just say a few things about the BMA. This is BMA House in London. The BMA is quite an institution. It was set up in the early part of the 19th century. And it's been functioning all over the country. We have a big headquarters in Tavistock Square with almost 300 people working there, a big policy division, a PR department, communications department, legal department, etc. Of course, many people know the BMA essentially as a trade union, but we are, in fact, largely a professional body concerned with standards, with education. Our job is to support individual doctors and members, very much a kind of a family situation. And like all families, I don't think all our family members are necessarily happy at the same time. And rather like my own family, some members of our clan don't necessarily even speak with one another and gladly put a contract out for someone else's life. I think you know exactly what I'm talking about. So these are some of the examples of the work that the BMA does, lest you think that this is merely a trade union. A lot of work along ethics, end-of-life care, though I won't go through the entire list, but these are all active areas at the moment, which are indicative of the large amount of work that goes on through the policy division, through the various committees, and each of the committees, for example, the ethics committee, the academic committee, and so on, has a remit to pursue things that are happening at a particular time. The aim is to try to keep as current as possible. And many of these points here are extremely hot, as you can imagine. And for example, assisted end of care, end of life is such a hot topic that it's likely to take up a considerable amount of time in the debates at the BMA conference this coming week. Within all this, the role of the president tends to be rather supernumerary, but I decided that I would chase down a BMA presidential project. And my project has been on the changing face of medicine and the future role of doctors in society, in the world generally. And this is where I want to invite you to take yourselves somewhat out of the immediate situation that you find yourselves in your own practices or in your localities. I would ask you to put yourselves into a slightly more hovering helicopter position to try to work out what's actually happening in the world of medicine, of healthcare, and how this might affect you as patients and where you might be able to exercise power. So if I may put it bluntly, perhaps I'm here not so much to answer why you cannot get an appointment with your doctor when you want one, or why you can't see the same doctor on every occasion that you want to, but rather I'm here to ask whether we can actually cope with what's happening in medicine worldwide and what these changes are going to mean for all of us and for our children and for our grandchildren. I'm doing this by taking us through a series of steps. First, I'm going to recognize some of the problems and challenges that are facing us and medicine generally. And then I'm going to ask us to start a dialogue on where the future lies. My key question is, are we actually facing a paradigm shift in healthcare? A complete and utter revolution of some sort, which is happening right now, but which we are slightly aware of, but not completely comfortable with. I just quickly want to explain what I mean by paradigm shift. The word paradigm was invented by Thomas Kuhn, who is an American sociologist, who described this little circle here, which is rather like a political revolution, where when there is an existing idea that's extant, or a certain way of doing things, which is very common and normal, now that particular idea or that particular way of doing things gets challenged by people who don't agree with it or have a new kind of thought, and that gets inserted into the way you think about things, and then the existing model of thinking or the way of doing things starts to get challenged, and then the existing model actually breaks down, and you get a complete change in the way things are happening. Let me give you a couple of examples. There are many doctors in this room, and the obvious example, for example, which most of us will be aware of, is that up to about 15 or 20 years ago, if you had a stomach ulcer, a duodenal ulcer, the usual treatment was tranquilizers to calm you down, psychological advice on reducing stress, perhaps drinking lots of milk and antacids, and operations to cut the nerves that produce acid. I'm sure there are people in this room who've probably had that operation. Well, it suddenly became known that ulcers were largely due to a particular infection in the stomach called Helicobacter pylori. And now it is possible with a 10-day course of antibiotics and certain acid suppression tablets to cure a person for life, and their ulcer never comes back. Now that is a paradigm shift. In the space of about 10 years, we have revolutionized the approach to ulcers. No operations are done. It's been a complete and utter change. Mind you, it did take doctors and the public a good number of years to come to terms with the fact that this revolutionary new idea had arrived. Nothing happens instantly. After all, even in the Navy, when we knew that lemons and limes were good for avoiding scurvy, it took about 100 years before the Navy started to issue those items to their sailors. Similarly, the arrival of the internet, it came rather insidiously, didn't it? Now, it's the normal method of communication. We've all accepted the fact that it happens. That's a paradigm shift in the way we think in the way things happen. And my theory is that we are heading for a paradigm shift in medicine, and we have to think outside the box to come to terms with it. There are many things that are happening. So here are some of the symptoms of the disease that we are suffering from. Doctors are suffering from high rates of burnout, and I'm speaking at an international level now. In the United States, burnout rates are so high that I heard one estimate that up to 10 or 15% of doctors are burnt out by the end of their 30s and 40s, and even higher proportions after that. By that, I mean that they are unable to work effectively, and if they go to work, it's under duress in a way that they cannot function with any degree of competence and effectiveness. We've got early retirements. You're well aware of that in the United Kingdom. We've got dropouts, people who do not complete their career training, or those who decide to leave their jobs, particularly in general practice, and go off to do other things within a so-called portfolio career or work with industry and so on. We've got severe recruitment and retention problems. Doctors train and often don't want to work in the specific settings where they might have to. Mental health problems amongst doctors, all health staff, but particularly doctors, are on the increase in an unprecedented manner. And as evidence for that, I can point you to the Royal Medical Benevolent Fund, of which I am a trustee and treasurer. And whereas in past years our recipients were normally aged over 60 or 65, the current age of our recipients is 35 to 45, largely related to mental health problems, depression, anxiety, substance, alcohol abuse, inability to continue working. There are severe recruitment problems in some specialties in the UK and in the United States in surgery as well. And we're going to have a crisis soon in obstetrics, for example, because people just do not want to take the risks and the onerous tasks that come with being a hands-on obstetrician. We've got dropping numbers of people applying to British medical schools. I know, as the Dean of Medicine, that this is a very contentious area. We're trying to increase the numbers of doctors, but the level of interest is actually now beginning to waver. Medical parents are discouraging their children from going to medicine, and we've got high rates of presenteeism. And by presenteeism, I mean going to work, but not really being there. Watching the clock, your mind is on something else. You don't really want to commit yourself to the job or the task at hand. You're biding your time, either until the end of the day or until your retirement beckons. Now, these are very real problems, together with very high suicide rates. And this, of course, is a well-publicized problem of a young doctor. And although this is written in rather journalistic style from last week's BMJ, rates of suicide in Canada, the United States, many Western countries around Europe, and certainly in the UK, are extremely high. And I know, for example, that the GMC is working hard now to try to improve the situation by relieving the pressure on doctors who are facing inquiries. Even though they might be completely exonerated, the interim period is extremely stressful. This, of course, when you're working in that toxic environment that I've described, you get a lot of other problems too. For example, interpersonal relationships between doctors which don't work out, bullying at work, and all the sort of miasmic atmosphere that gets created in an unhealthy situation. You need to know this. I need to know this. I'm a patient. You need to know this because you are patients too. This is the backdrop to what's happening in medicine. And it may surprise you, friends, colleagues, that our situation in the United Kingdom is relatively good compared with many countries in Europe, and certainly much better than in the United States, and probably better than the situation in Canada. For example, Norwegian doctors, junior doctors, were on strike for several months continuously last year. And there have been legal actions in many states in the USA and problems in Canada in terms of the way doctors work and what work they're allowed to do. So what are the causes of this? Oh, you might say, oh, it's too few doctors, and there's too little time with patients. That's what's upsetting us. Okay, well, you might say that, but ask yourself critically, so where are these hundreds of millions of new doctors going to come from all over the world? Where are we going to find this extra time from? Loss of continuity and personal knowledge of patients. Yes, I know. This is what happens to us in general practice. When our work begins to waver because we don't have those ongoing relationships with our patients, we become frustrated, angry and burnt out. Of course, some patients do burn us out as well, as I'm sure many patients in this room have been burnt out by their doctors. The corporatization of health has been a modern phenomenon. By that I mean working for a large employer, either in the United States or some European country, or in the UK within the NHS. And the corporatization of health means that you're working within a situation where your professional values and the way you want to work is being overridden by the corporation within which you work. You can't easily whistleblow, you can't say what the problems are, because your organization has a hierarchical structure and a PR or communications department which has to do that. Now, you simply have to get on to do what it is that you have to do. This is a major blow to the way doctors are trained in terms of their independence and professionalism. We have the commodification of health. We can no longer make decisions without taking into account how much that decision might cost. I know there are people from CCGs here. It worries me that CCGs are making decisions about who can be referred to hospital and who can't. This is going to hit the GP in terms of her psychology. How do you know whether what you're doing is right? What do you do about the necessity of a second opinion? What if you feel that you're not certain? Is cost everything? How can you decide what you're going to use and what you can't? Professional conflicts with employers, a changed relationship with the public and our patients. Our patients are better informed than we are with regard to many of the problems they have. I recently had a health problem, and I realized that actually I knew very much more about it than my own doctor, because I read up about it. It wasn't just the fact that I was a doctor. Information has escaped. We have what you call the democratization of knowledge now. It's all out there. This has led to a new relationship with the public. Loss of previous status, and all the other areas here which I don't need to go through bit by bit. But these are the kind of stresses that we are facing. And if you think along these lines, then you will realize that these cannot be simply turned round by some legislative process. It's not a question of saying, right, we shall triple the amount of money in the health system and quadruple the number of doctors. It's just not as easy as that, because what's happening is a sociological shift, a dynamic that has changed, and we are living in a new world which is barely recognizable. If you talk to our children, for example, their approach and attitude towards healthcare and medicine is so different from the ones that I and our older members of our family have had. So here's some evidence about how tense the situation is. This worrying slide tells you of the proportion of doctors who train and become doctors and complete their compulsory foundation program, in other words, the old house job for registration. You will notice that in 2011, over 70% went into specialty training, in other words, what you would have called a registrar job to become something or the other, a heart specialist, a gastroenterologist, or whatever. Just look at those numbers. They've dropped from 72% to 50% last year. Half our doctors, as soon as they complete their compulsory training, are not going into further training in the NHS. The NHS is not sustainable on this basis. So you might say, something needs to be done. But no, I would say something needs to be learned from this. Now, the bottom bit of the table there tells you what's happening to these people. As you can see, 13% are taking a career break. Only a tiny proportion are leaving the profession at this stage. Quite a few, 12.7%, are going abroad. And a good number are going into jobs outside the NHS, for example, in the military, in industry, and so on. But this gives you a clear message. Doctors are not wanting to be doctors as much as they used to in the past. This worries me. The general practice situation is just as worrying, if not worse. We all know, I don't need to stress the point, that there is huge difficulty in recruitment and retention in many parts of the world. And this particular slide, which comes from research done from the Southwest around here, indicates the difficulties that are going to arrive. So look, if I'm being very fair in my own situation about my own practice, that is to say the practice where I go to see my own doctor, it is likely that they are not going to be fully manned or womaned or whatever word you want to use in the future. It is highly unlikely that there's going to be adequate provision of the sort that used to happen 10 years ago. We're living in a world where, for example, pretty much the whole of North Wales does not have any fixed practices, and it's run by a series of conglomerates that try to provide locum doctors or salaried doctors on an ad hoc basis. And this is happening in large swathes of the country, in the northeast, for example, and certainly in places which are not very well off in terms of their economic structure. So this is just a fact that we have to face. And again, I stress that the situation is considerably worse in the United States, in Canada, and many other parts of the world. Australia, too, is facing up to this, and New Zealand has a major crisis in terms of recruitment and retention. They may well have another crisis at the end of the day today, but we have to wait and see. At the same time, this is something that we have valued greatly. Continuity of care, the reason I went into general practice, the one-to-one relationship, the ability to get to know your patients, and how helpful and useful that has been in the basic tenets of being in a primary healthcare system. And we know that familiarity produces better outcomes, and this research paper confirmed that continuity of care is good for patients, reduces costs, and has indeed, of course, been the traditional basis of general practice. But again, I ask you to take this fact and examine it critically. This may be what we all aspire to, but this is not what's happening now. And it is extremely unlikely to be reversed in the near future. Even if the government's promised to produce 1,500 new doctors, or I can't remember the exact numbers now, 5,000 new GPs, well, if we take in the number of students we do now, and if we take into account that it will take a minimum of 9 years to produce a doctor from scratch, there's no way we're going to have an additional 5,000 doctors even in 9 or 10 years' time. We're facing a new world, and those doctors may not want to go into the present structures of work that we have. And I know this is a meeting primarily about general practice, but this is important too, because the systems in hospital aren't working very well, and this report from the College of Physicians confirms low morale, which then represents a threat to patient safety. So I want to leave you with a number of questions. Are we actually out of step with society? I don't want to sound as if I'm attacking anyone in this room, but I've been to several meetings with patient colleagues, and the questions that come up are the usual ones. Why can't I get an appointment with my doctor? Why is there a delay in the time that why can't I be seen by someone I recognize? I would ask you to hold that back for the moment, and rather ask yourself whether there's a bigger change out there. It's not so much what's happening in your own practice, in your area, but it's much more about what's happening the world over as far as doctors and medicine is concerned. Let me give you some more examples. In China, should a doctor treat a patient who then comes to harm or dies because the operation went wrong, that doctor risks being killed. And there are several hundred killings of doctors every year in China, because that society has developed from a society of low expectation of doctors to one of very high expectations in a fast-moving economy. And people are not forgiven for either making a delayed diagnosis or for missing a diagnosis. And I've been to China on 3 trips now, and quietly they will tell you of this crisis that they have. They essentially do not want to engage with their patients in case they come to harm. They want to do their jobs rather mechanistically. In India, it's cowboy territory. You have no way of knowing whether the operation that you're about to have done is the operation you actually need. Because there's a great deal of intellectual capacity, technical competence, and high-level machinery and technology available. And this is, in the main, a service that's there for profit. And it's very confusing. Now, these are all models that are breaking down. In South Africa, the situation is the same. We're actually at a point of crisis as to who we are as doctors, what our role is, what our sense of vocation is. And, of course, are these colleagues patients? Are they consumers? Are they members of the public? And if you come in well armed with information, and you know exactly what you want, and you know which drug you want, then the encounter with the doctor is quite different from someone who is coming in as a supplicant seeking advice. And this shift in relationship, I think, is going to make a huge difference to the way the future goes. So in wrapping up now, I just want to make a few reflective remarks. One of our current big-time thinkers is someone called Don Berwick, who says that we're in the third phase of medicine. The first phase was the era of, you could say, the apostolic phase, where doctors were patronizing, relatively superior, intellectually able. One of my friends described this as the pre-Calvin age, pre-Luther age, where the priests knew how to read the Bible and did the sermons, and the rest of the public was relatively on the outside. So that was the era one of medicine, which in many countries is still rampant, but in most Western countries has disappeared. The second era, one of evaluation, measurement, performance, something which many people in this room, including a colleague who's going to speak next, will feel very strongly about. And of course, the GMC was required to put performance measures and evaluations, revalidation into place as a result of many things that happened. You could call this a natural evolution. The third phase, Don Berwick says, is to abolish the second phase and to reinvent doctors as people who are concerned about other people and who can hear the voices of the people that they are serving. How do you create such an atmosphere? How do you create such an environment? How do you actually move into that very interesting and exciting world? Now, that's what my project was about. So these have been some of the questions that I want to throw out to you. These changes that I've described, what do they mean for you and for me? Does this mean that because of fewer doctors and other technical staff, there just needs to be a redistribution of work? Do there have to be new invented professions that will take over the roles that we so value? Or in fact, is it the fact, or as someone said, is the doctor going to have to be wiped out and reinvented as some kind of new being with a completely new remit and perhaps a completely different sense of vocation? Perhaps we're not the priests that we were in era one. So what are we going to be like in era three? We need more accurate diagnosis. We need earlier diagnosis. We need to reduce clinical gambling. You cannot anymore simply say to someone who comes in with abdominal pain, well, look, it doesn't look too bad today. Try these painkillers and we'll see how you are in 6 months. Because if something goes wrong, then no one's going to forgive you and you've not done your job. But our present system, unfortunately, encourages that, either to save money or for the sake of expediency. And we also now have much better technologies. We're not working in the 19th century anymore. We have ways of diagnosing things much earlier, much faster, which means that our workforce, especially in general practice, needs to be much cleverer, much smarter, and better informed. It's not just a question of continuity. You need to be slick and know what the latest developments are so you can order those tests and use those diagnostic modes. Those who are working in CCGs, please take note of that, because you cannot hold back the tide of development and technology. All you can do is try to hold back costs. These are the advances that are arriving. Personalized care and treatment. You know, and if I make this example rather glibly, please don't take it too seriously for yourself, but if you have 5 women with breast cancer, it is quite likely that each of those 5 women will have a completely different treatment, because that treatment is geared to the exact cancer type they have. It'll be geared to their own genetic makeup. It'll be geared to the way that the cells in that cancer are developing. And that kind of precision medicine is now extremely important. You can actually create drugs for a single individual with a single syndrome through a better knowledge of their genes, their cells, and so on, and getting to know about their genetic coding. So earlier and more reliable diagnoses are on their way, together with artificial intelligence, which helps to make decisions in a more accurate manner as a diagnostic aid. We have liquid biopsies. By liquid biopsy, I mean biopsying something without actually going into it. So for example, where right round the corner, we have liquid biopsies for prostate cancer, no longer needing to go into the prostate with a needle to take out cells to look under the microscope, but rather to take a blood sample which measures the genetic signature of abnormal cells that are floating around the bloodstream. And these abnormal cells are produced by the prostate. That's a liquid biopsy. And by looking at the genetic makeup of stuff that shouldn't be in the bloodstream, it's possible to identify the exact prostatic cancer that a person might have, and through a process of engineering rather than drug discovery, drugs can be made to be tailored to that exact kind of cancer. So, what about our traditional core values? I've always believed in these: trust, competence, compassion, sympathy, empathy, vocational care. I heard one eminent speaker say in a quiet voice, "These are killing us. We can't go on like this as doctors." Isn't that an irony? And I think this is where, working with patients, we need to understand the dynamic that's happening at the moment, the shift that's taking place. And of course, everyone knows this, that if you're going to have a new system, it's not just merely a question of developing things. You sometimes need to reinvent stuff from the very start. I like this quote from our common colleague, Sir Donald Irwin. I'll let you read it gently, but what he says is that we have to stick with the concept of active patient autonomy. It is the patient who is the final arbiter of what's right for them. It's the patient's body, their mind, their illness, and their life. I believe this wholeheartedly, and this, I think, has to be the motto and the strapline through which the public and the patients have to bring influence to bear upon governments, upon professions, to make things change. So I too am a doctor, and I find the current situation as a doctor and as a patient. I too am a patient. I find the current situation confusing from both sides. It's not easy. I think we're stuck in some kind of middle ground as this paradigm shift and revolution takes place. I don't think patients, doctors, and medicine are ever going to be the same again. And it's going to arrive very quickly. And a lot of our current frustrations are due to the fact that this revolution is happening right under our feet. So I would urge us to remain active participants in the future. It's not enough, in my view, Patricia, to be local activists. I think that's important. I think there needs to be a major move to influence not just governments, but the public to recognize that there's a change happening. And perhaps to come to terms with the fact that yesterday's best system isn't going to exist in that particular format. We as patients may need to change the way we approach healthcare. We may need to cope with a fragmented system of care, and one in which we may need high levels of advocacy to get what we want. I think that this is extremely important for us as we develop further. So I'll leave you at that, but I'll be glad to answer questions and take comments later. Thank you.